What is going on, everybody? It is Mark Cargilla, lead faculty and CEO here at Modern Pain Care, where we make you the complete clinician. Coming at you today for another episode of the Modern Pain Podcast, and this one near and dear to my heart. It's another topic that if you've listened to this podcast and you can hear my blood pressure raise with some of these episodes. This is one that tends to, just because it's a passionate topic of mine, it's a place where I spent a good chunk of my career thinking it was the answer. And I don't want to go to the point it's useless, but because it isn't. I think that's where a lot of the discussion and ridiculous dichotomies that get created. But around manual therapy and segmental specificity, and there was a nice review article that was recently published in the Scientific Reports Journal out of like the Nature group. So a high-level journal. I mean, it's one of the higher-level journals. I can't remember their impact factor and all those fancy journal metrics, but they spoke about it. We're going to talk in detail about it and how it kind of relates to what we've seen in our experience. And kind of just summarize the study, just so you guys can, and give you guys obviously the citation and all that good stuff, so you can take a peek at it and look for your own self and see some of the things that go into it. Jared, our partner here, has posted to social media, and he can talk about it because he of course put the research out there and had a nice meme to go along with it, and some pretty respectful discussion as far as I know. I haven't peeked at the detailed comments on it. We'll get into that a little bit, but before we do that, let's hear how Jared Hall and his international travels are going. How you doing, Jared?
Hey, man. Good to be back. I definitely enjoyed going over to Europe. Got to pop into Strasbourg, France. Got to pop into a few different cities in Germany: Heidelberg, Nuremberg, Stuttgart, Frankfurt. Got to pop over to Prague. Which, man, if you haven't ever been to Prague in the Czech Republic, I strongly encourage you to go. One of the coolest cities I've ever been. But after traveling, being on the run for a while, it is good to be back home. Good to be back in the studio talking with you, and of course diving back into looking at research and seeing what's new in the PT world. So it was great timing that this study was published online. I think it was author's first author's last name is Nim. Published online December 3rd. So I got back December 4th. So this was published one day before I returned home. So it was fresh. There's lots of fodder to go over. So this is something that you and I have talked about a lot. And we've talked about some of these individual studies in particular that this review article, the systematic review, included. But it's cool to actually see somebody go through and systematically review the available evidence and kind of put it all together to create some comparisons with a larger patient base and see if we can get a little bit more robust evidence. I'm looking forward to talking about this one.
Yeah, no, I think it's a good study. It tickles the biases, of course, and it definitely is one, like I said, as I'm trying to over automate things. Let's talk a little bit about the setup of the study and kind of how they performed a systematic review, because I think it's worth discussing as far as looking at some of the nuts and bolts so people can see how they gathered studies, what they looked at. Because there were some different components of the study that I thought were interesting. It's a well done systematic review. They followed all the guidelines that you need to follow. I can't remember the exact tools they used to make sure they were performing these reviews up to Cochrane level standards and all that good stuff. They use a Cochrane level, tool for risk of bias, which I think is important, especially around manipulative studies where, shockingly, people who manipulate and teach it, research on it, and might have a biased view on what's going on in there. So you got to, take that into account as you read studies. But do you mind kind of discussing with the folks who are listening, what did that study look like as far as, what did they do, how many studies they ended up looking at, and, we can go further after that.
Yeah, sure. So first, what I'm going to do is just go ahead and actually say the full title of the article. So if people want to look this up, and of course we'll have it in the show notes, but it's "The Importance of Selecting the Correct Site to Apply Spinal Manipulation When Treating Spinal Pain, Myth or Reality, a Systematic Review." And that's author's last name, Nim, N-I-M. So it was I liked this study because they did not lump mobilization and manipulation together, right? And in some different cultures, some different countries around the world, if you say manipulation, that could include high velocity, low amplitude thrust, as well as joint mobilizations and low amplitude manual therapy. But in this review, they specifically searched for high velocity, low amplitude thrust techniques. So what we would call spinal manipulation, right? Or an adjustment looking for trying to elicit the cavitation, or the clicky poppies is what they were looking at. And they ended up, after searching multiple databases, I believe from the year 2000 to present day, it was about a 20-year span or so. They came away with 10 articles that actually fit the bill, that were spinal manipulation, that looked at specifically primary outcomes were patient reports, so subjective reports of improved pain or disability. And then secondarily, they looked at objective measures as well. So improvements in range of motion, improvements in strength, that sort of thing. Improvements in things that you could actually physically measure as an assessor, rather than going on subjective reports. So they broke it down into 3 different categories. They were kind of trying to compare between. So the first category was spinal manipulation applied to a target site as compared to the other side. So let's say you've done whatever assessment technique you do: palpation, palpatory assessment, passive accessory, intervertebral motion assessment, side glides, little pressy guessies, pokies, whatever it is. And you've determined that C4, C5 is the target area on the left that is dysfunctional in a patient. So they compared manipulating C4, C5 on the left to C4, C5 on the right. And they were looking at, is there any difference? Does it matter which side? Do we see any difference in patient-reported outcomes? Do we see any difference in objective measures? The second group that they looked at was spinal manipulation applied to the target site as compared to the general area. So that would be, you've determined that somebody has a problem at C2, C3 with whatever your assessment techniques are, and they compare targeted spinal manipulation to C2, C3 on the left side to maybe just doing like a general mid-cervical spine manipulation or a lower cervical spine manipulation. So you're still in the same region, but you're not directly trying to target that super specific level that you determined with your hyper-specific assessment approach is dysfunctional. And then finally, the last group was that target segment. Again, we'll say C2, C3 on the left, as compared to just doing like a mid-thoracic spine, manipulation technique. So you're at a distal segment or a distal location, or maybe even going as far as somebody had lumbar dysfunction and you manipulate the mid or upper thoracic spine. So across all 10 of the studies that met the inclusion criteria, various ones of those studies kind of compared those different target treatments. And every study didn't compare each one of those target treatments, of course. A few of the studies compared ipsilateral to contralateral. A few of the studies compared target treatment to the region. A few of the studies compared target treatment to a distal location. And they assessed for risk of bias. And surprisingly, all of the studies but one were fairly low on the risk of bias scale, which was encouraging to see. That means the researchers were doing a pretty good job. They were declaring conflicts of interest. They were declaring if they received funding. They were blinding patients adequately. They were blinding assessors adequately. So they really brought down the risk of bias. There was one study that was rated as fairly high risk of bias based on the way that it was conducted and patient blinding and not disclosing conflicts of interest and that sort of thing. So overall, we could say that this is probably a pretty decent first pass at this type of evidence. So before we go any further, just wanted to see if you had anything to add to that, Mark.
No, I think the risk of bias that they talk about, random sequence generation, allocation, concealment. Some of these things are difficult to do. The participants were naive to spinal manipulation treatment, which I think is important because if you conduct studies and you're biased, where this is what we do, we manipulate, we click and stick, or we do whatever, and that's what we define ourselves of, and we create an environment in the context of humans that are salivating to have that done to them, then it's probably not the most unbiased place to conduct a research study there. So I like that as part of it. Blinding of outcome assessment, making sure the folks that are assessing outcomes weren't the people that are delivering treatments. Also incomplete outcome data, that, intention to treat analysis type thing, where they're looking at, hey, if people are dropping out, are they still getting included in the data analysis? And then you're reporting, you know, there's significant, your clear discernible reports of how many people are dropping out and not. Obviously, people that don't drop, if there's a big dropout rate, and yet the people that stayed in, of course, are going to be a biased sample of people that had a positive response to things. Selective reporting, and there's other sources of bias they looked at too. But I was, kind of impressed too. There was decent, risk of bias thing. There was one high risk of bias, a few moderates, and I think 5 low, which is good. There's always going to be bias. We're humans. I don't think there's ever going to be a perfectly bias-free study. But obviously, there's things we can do. And we, as like I'm some sort of high-level researcher, but things that researchers can do to help mitigate the bias as much as possible and create more of a is less of a contextually influenced results in their theory, where it's more, hey, can we truly strip it down to the mechanisms of the tool under study, not as and take as much of that extraneous influential variables out of the equation. So I think that it's a great review. I thought they did a good job, really following good methods, and came up with some interesting results. So what do you think? We're time to start talking about those results?
Yeah, let's go ahead and jump into that. And I want to first of all encourage anybody listening to go read this study yourself. Like we could talk, we could word vomit a bunch of the results and that sort of thing, but that's not good for a podcast medium. So I would encourage you to go actually read this, and don't always necessarily take our word for it or anybody else's word for it. It's good to get your eyes on this data. It's good to see how they designed the study, and learn about it yourself, and get better at reading this type of information. But if we go ahead and kind of gloss over the nitty gritty details of the results, what we can see is their conclusive findings, or what the authors came away with. They ended up looking at 31 different metrics, or 31 different outcomes, from pain pressure thresholds at different sites, to range of motions at different sites, to strength measurements at different sites, to different ways to measure patient-reported disability. And the direct quote is, so the systematic review included 10 randomized controlled trial clinical studies, of which 9 were considered to have credible results. None of the 9 studies detected any statistically significant differences in the 31 outcome measures for the 2 treatment approaches. In other words, spinal manipulative therapy given a clinician-determined correct vertebral level did not have better outcomes than treatment given more haphazardly. So I think that's a really interesting statement for a couple of reasons. Number one, they did point out that one of the studies was a high risk of bias, and the only study that showed any positive results was also the one that had a high risk of bias. So that's really important to remember. When you have researchers actually going through and assessing the risk of bias in a study, that should give more and less weight to the results of that particular study. So when you use a risk of bias assessment tool, and it has a high risk of bias, and that just happens to be the only study that showed statistically significant differences, that should raise a little bit of a red flag. Then the next thing that should jump out to you: none of these 31 outcomes showed even statistically significant differences. And I think that that's something that a lot of people gloss over, because oftentimes we don't think about the difference between statistical or clinical significance. And typically, almost always, you will see statistical significance before you see clinical significance, right? So we can say that their pain, a group of patients' pain changed, 1 out of 10 in the numeric pain rating scale. And that can be a statistical difference, but then that hasn't actually achieved clinical significance. So we can say, well, in one group, their pain decreased from a 5 to a 4, and in the other group, it decreased from a 5 to a 3.5, right? And there's a difference in there, and that difference is statistical, but it's not clinically relevant, because what patient is really happy about a difference of 0.5 or zero point 0.7 on their outcome, on their pain. So that was another big thing that jumped out to me. And then finally, I like that they use the word haphazard approaches. So looking at highly specific manipulation techniques versus a more haphazard approach. And what that brought to my mind was in the chiropractic world, and this is not meant to be a slight on chiropractors at all, but I have some buddies who are chiropractors who told me about a concept of what's called the flying seven, where every patient that walks through the door in the chiropractic mills, the clinics that are just rack 'em and crack 'em type of clinics that aren't doing a lot of assessment or true nuanced rehab, they do the flying seven, where you crack cervical spine to the right, to the left, you do upper thoracic, you do mid thoracic, you do lower thoracic, and then you do lumbar on each side. So there's your 7 techniques. It takes about 5 minutes to do. You can crack somebody everywhere. And if they have back pain, like that's the super back or neck pain, that's your super haphazard approach. And what you're doing is you're just flying high on either meaning response and contextual effects, or very general non-specific effects of manual therapy. Some things that maybe Joel Bialowski has talked about with his mechanisms of manual therapy talk. And you don't have to do this highly specific intervertebral assessment, palpatory examination, motion palpation, etc. You just people just walk in, and if they're safe for it, you just give them a little bit of manual therapy, and they're going to have the same response as if you do this highly specific technique. So I can see you're like chomping at the bit to talk about this, Mark. Let's hear what you have.
Well, I just think, I can already, I just reflect back to parts of my career where I was like in the specific manual therapy bandwagon. I was a card carrying member with lettered polos of support on the specific manual therapy front. This would have been a struggle for me to take this study in. And I would have, probably had my cognitive dissonance rolling high, because it was definitely a conflicting piece of data for the the world I was living in and the comfortable world I was living in. So, but to me, this is further reflection of the manual therapy worlds of profession. Now, I think we'll talk about an episode. Is there some things where maybe specific manual therapy, although probably a lot more than this mechanical Jedi hand tricks that we've convinced ourselves and still try to convince ourselves is a reliable way of getting after it? Or are there things that happen when you specifically find a person's pain specifically? But again, we may not get to that today, but it is long since past the time of put up or shut up for those systems that still beat these segmentally specific models into a student's head, where we got to go through 15 levels of Jedi training to be able to, it's such a highly skilled, to me, it's this old boys club of like, man, you got to kiss the ring and go through the levels before you can say you're part of the club, which to me is ridiculous. I went through that and achieved my Jedi stat, or maybe in my own mind I thought I did, as far as, but achieved that level to, oh gosh, you've been now certified and knighted in this Jedi skill of manual therapy. But I think these studies are, how much longer do we have to like bury our head in the sand before we kind of peek it out and see that, man, what we're telling students, what we're telling clinicians is not necessary. It makes us probably feel better, especially if you levered yourself as, identified yourself as a manual therapist. But man, it's time to move forward, especially when it doesn't freaking matter and patients don't care of like that stuff. I mean, they might care about the ritual you create with it and some of the unnecessarily, overly, ridiculously complex rituals around it. But if these studies, and a lot of these folks, chiropractic and PTs and stuff, I think everybody's seen that it doesn't necessarily. No, does it mean haphazardly? No, I think there's a lot less, need to be ridiculously specific. You still need to be good at screening, making sure people, who are in your clinic, that neck pain and headache isn't a dissection in progress going on, that you're going to be, putting that person in, risk. They should be going to the urgent care or emergency department, not, laying down on a table, getting their neck cracked, those type of things. Still, there's some skill of deciding that treatment. I don't get too excited if people crack or don't crack anymore. I just think it's yet to show its special in regards to any short-term pain modulating intervention. But maybe we'll talk a little bit about more of that. But I think the study also discussed a bit of some of the things that they thought, some of the clinical discussion around what they found with this, their clinical interpretation. Did you want to go into that, Jared, or do we want to save that for episode 2?
Yeah, I think we should save that for episode 2 because it starts getting into the discussion of, you know, does manual therapy need to have any specificity at all? And I think that if we start that now, this episode is going to run about another 30 minutes. So
Yeah,
we should
yeah.
probably break it down.
For sure. So, stay tuned for episode 2. We're going to talk about some of the authors' reflections, their clinical interpretations, which I thought were good. Definitely tickled the biases of what we teach our students to try to, put manual therapy in a perspective of not living in any ridiculous side of a dichotomy that patient doesn't exist in the world of patient care. So we'll talk about that, and we'll talk about, maybe is there ever a time where like segmentally specific or getting specific might generate better responses? What could be some of the reasoning behind that? Obviously, beyond Jedi millimeter sensory tricks that we, still continually, can try to convince ourselves that we're capable of. So, hey, big teaser there. I thought we did a great job teasing our next episode. Hope you guys tune in. And before you wait that week between the episodes, let's temper any hate mail down. I'm just kidding. No, we'd love to hear your thoughts on what we talked about this episode. Your thoughts on the article. We're probably going to talk about it in episode 2 because we're probably going to record episode 2 here quite quickly. But we'll definitely, if we have some great discussions coming around that, maybe we'll do episode 3 of the discussion around this article, because it usually brings out a lot of passions and good discussions. And let's just keep it collegial and make sure nobody's, insulting each other or throwing any ad hominems or anything at each other. Let's make it a nice, good discussion. But hopefully you guys enjoyed the episode. Make sure you tune into episode 2 where we go deeper on, like I said, the interpretations of the study and how it might relate to your practice. So until next time, we'll talk to you then.